Good evening, everyone. I know for some of you, you're probably just finishing with patients like I am. We just wrapped things up. And some of you, it's on the little bit later side that you're on the East Coast if you're in Canada. So tonight, as Jordan and Isabella mentioned, this is an exciting webinar. We give a lot of, NewSmile is amazing with content as far as, clinical content when it comes to crowns and other things. And then, of course, with intraosseous local anesthesia that we're going to talk about tonight. But there's a big announcement that we will talk about. Some of you may have heard this, but we had the big kickoff for a new product that really has changed even more so the way that I deliver local anesthesia in my practice. So tonight we're going to go about an hour, and then we're going to leave time for questions. If you have questions, as Jordan mentioned, please go ahead and put them in the chat. If there's something that's really, really pertinent that we think should be answered right away, Isabella and Jordan will go ahead and stop me. And the other thing is all of you are going to get my contact information. So we're going to go over a lot of information tonight. It's going to be a little bit of a fire hose. And I know sometimes some of the comments we get is, you're going too fast or there was a lot of stuff. I know, but we just try to pack in as much information as we can. But I'm reachable pretty much all the time. So if you have something, you're going to reach out to me or any of the KOLs we're going to discuss tonight. So on behalf of myself and NewSmile Tech and Dental High Tech in France and NewSmile, I want to introduce everyone to the webinar tonight. So if you've been on one of these before, you may have seen the intro webinars. You may have seen the mashup, which is kind of in between of what we're doing tonight. And then tonight is one of the mastering series. So it's really designed for those of you who already have intraosseous anesthesia. But if you're new, usually we get a fair amount of new people on here. Great. We're going to show you a bunch of stuff. But you may also want to go back and look at some of the intro to intraosseous anesthesia that's recorded. Those are all on NewSmile's website, so you can get them. All right. So one of the big announcements here, if I can go forward tonight, and why this mastering session is a little bit different than the others, is we've got a big announcement. Some of you have already heard that the third device in the series for delivering intraosseous anesthesia came to market last year after a whole lot of time and redoing a lot of research that was already done and a lot of jumping hoops through the FDA. And I really don't want to know how much time and effort and dollars were spent to get it here, but I'm very grateful for NewSmile and NewSmile Tech and Dental High Tech Now Americas for bringing this device especially to us. So we're going to talk about tonight, and this is really the official kickoff for pediatric dentistry. We were at the CSPD this weekend, Isabella and I, and a lot of crew from NewSmile, and that was a big announcement that QuickSleeper is here, and it's now going to be taught to pediatric dentists. When it first came out, was really geared, all the advertising and all the education was really geared to our general dentist colleagues, but this is the official launch for QuickSleeper for us as pediatric specialists. Okay, and by the way, it's my IO birthday, so happy birthday to me. I just, any day, I'm going to hit 2 years with the SOAN and SleeperOne. It was 2 years ago a little bit before 2 years ago, where I was introduced to these devices. And, once I saw the SOAN and SleeperOne, I realized very quickly that it was something that I wanted to integrate into my practice, into my teaching center. I try to be pretty tech forward in things I do, and I try to integrate. If I see something that I think will really help my patient care and help myself as a clinician, then I try to hop on it. And so now it's been 2 years. I literally cannot imagine administering local anesthesia to a patient under 14 with a standard syringe. I can tell you in this entire time, I really committed. I said, once I get my SOAN and SleeperOne, I'm going to learn and I'm going to put the standard syringe away. And I have only used the standard syringe a handful of times in the last 2 years, maybe during general anesthesia, or if one of my associates grabbed one of the devices and I didn't grab it back fast enough, I've used a standard syringe. I have not given a block to a patient who is 14 and over since, or maybe one time I had to, because I think one of the associates grabbed it, but I may be given one block to a patient over the age of 14 since August of 2025. So I did not get balloons or a cake from Jordan. Thank you very much. But maybe next week something will come into the mail. But in all seriousness, I feel like I finally, now with the introduction of QuickSleeper5, I feel like I really have a solid understanding of how intraosseous local anesthesia works. Now that I've been able to administer these on teenagers, and I do some adult dentistry, I really was the trifecta of me understanding the anatomy and really in detail how the process of local anesthesia works with IO administration from patients from zero to, I treated a friend who was a prosthodontist, retired, and he's probably in his late 70s. I don't do a lot of adult dentistry, but you can use this device really for any age. So we're going to talk about that tonight. So just quickly about me, I'm a second generation pediatric dentist. So I'm a spoiled baby. I got a practice handed to me, and that's why I'm always, my heart goes out to all of you that are starting from scratch or started from scratch. I'm always available if you need help with practice management questions, especially anything with IO. And you'll see some other people that are very involved with New Smile and teaching intraosseous anesthesia. On the upper right there, that you can scan that for that QR code for my contact information, or on the lower left, my email address is there. So joshua@pediatricdds.com. I snagged that one 20 years ago. I'm not going to give that domain up. Or my website for all my teaching is www.pediatricdds.com. And about 2 years ago, I moved into a new facility. So I was in a much smaller office and moved into a much bigger office. So now we're at about 6,000 square feet. And I also have an integrated teaching center. And I'll talk just quickly about that tonight. But tonight's really about intraosseous local anesthesia. So a couple disclosures at first. So number one, any of us that speak about intraosseous anesthesia for these devices for New Smile, Dental High Tech Americas, we do not receive any payment remuneration from the sales of these devices. So although it'd be nice, I don't get like a 2% kickback for each unit that's sold. If I'm speaking, I do most of the time, get an honorarium, but tonight I have chosen to volunteer my time for all the time it took to put together this webinar and to give this webinar tonight. And I wanted to do that just to show that I am completely independent. I don't have a dog in this fight. And I really believe that intraosseous anesthesia, the delivery of intraosseous anesthesia for children and teens and now adults, should become, and it's getting there, the standard of care. And by me volunteering my time and all the time I'd spent putting all this thing together, that's just my way of showing that it's important to me and that I'm not a paid talking head for the night. So there you go. Maybe Isabella will buy me lunch or something when I see her next. Another disclosure. Tonight is going to be really focused more on the advanced topics. Okay, so we're going to talk heavy on QuickSleeper5. We're also going to cover some advanced topics with both the SOAN and SleeperOne. So if you are watching this on a recording, or if you're new to these devices, some of this, we are going to go over some basics, but there's a whole library of information that's available to you. I don't even know how many webinars we have available now, but there's a large number of introduction to IO anesthesia, and that is on New Smile's website. You'll find all those there split up by techniques. So as far as crowns, cements, space maintainers, scanning, that's separate, but dental high tech, all the New Smile tech, those videos are separate. And then any information that you hear tonight or you watch in the future, just know that it's all up to date till today. So don't watch one of these 3 years from now and then get mad pricing or change or something. I don't have anything to do with that, but it is all applicable till this evening. So that's just really quickly about my office. So when I opened, we moved into 14 chairs and then enough room for the teaching center. So when I'm not seeing patients, I have hands-on courses in office, or I'm out lecturing and things. My office, we really try to keep things bright and open. I didn't want to go to an under the sea theme or something. So we really wanted this to be comfortable for all ages. And as I mentioned, when I do teach courses for New Smile, we just did a training not too long ago on QuickSleeper5, or for other things, we convert everything over to a learning center. And there's Lauren, who is my model for the picture on the right. As a gift for all of you, anyone that's interested, you can take a scan. This is my directory of all my current patient handouts. So everything from over-retained teeth to primary hepatic gingival stomatitis, spacer care, general anesthesia. There's probably about 20, 25 handouts in there. All of you have my permission. You can take my name off and put your own logo on. I will ask if you have any good handouts that, and actually we need to put some handouts for IO in there. I just thought of that. We will start adding things in there, but those are all available to any of you. Feel free to take any of the handouts and make them your own. And if you do have a good one for your practice, please send it over to me. I'd be happy to add it to the pile, but I'm really trying to add to the collective information for all of us for pediatric dentistry. And if you're new, making all these handouts takes a lot of time, and I've been doing it for a long time, so I'm happy to share them. All right, and then the last little slide about me. This is just a quick shameless plug about my learning center. I teach, during these courses, we do talk about SOAN and SleeperOne and QuickSleeper, but mostly this is hands-on direct composite, learning how to really place good class 2s, fracture repairs, peg laterals, all that fun fee-for-service stuff. And this year now in 4 different states, so California, Washington, Minnesota, and a few of them in South Carolina. So if you're interested, it's pediatricdds.com, and that's my only shameless plug for the night. All right. We're going to take a poll, and Jordan, I'm going to turn it over to you. We're doing a poll tonight?
I actually don't think we are. Let me double check. No, I don't think we're going to do one tonight.
Okay. Yep. Good. The poll takes a long time, so we are not going to do a poll. Perfect. So I just want to introduce 2 other people to you, and you can see on the upper right, that's the photo of the QuickSleeper5. Now, there's a lot of key opinion leaders and a lot of people that know quite a bit about SOAN and SleeperOne, but because the QuickSleeper is new, there are 3 of us really that are certified trainers as pediatric dentists, and the first is my dear friend and frequent teaching partner, Ann Bynum, who is in South Carolina, and there's pictures of her beautiful new facility. It's just slightly over 10,000 square feet, makes my office look tiny. Her beautiful classroom there. Ann's information's there on the upper left, and she can be one of the people to help you with QuickSleeper, SleeperOne, and SOAN. I have to remember all 3 devices. And there's a little bit about Ann and also her husband. So Matt Bynum, who is one of those super GPs who does everything from 9 million implants to surgeries to full mouth rehab. And he is the lead KOL for and trainer for the QuickSleeper5 on the adult side of things. So they practice together in that beautiful facility. And Brian Richards, who unfortunately he can't be here tonight because he's in Costa Rica. Oh, so sad. And he just texted me this too. I guess rub it in. There he is watching the webinar live. Hi, Brian. He's out there watching somewhere on a beautiful beach while the rest of us are working. And in all seriousness, Brian, he lives in the pediatric dental world and the adult dentistry world. So he's one of those rare people that is a certified pediatric dentist. And also, I think he spent a third of his life at LVI and doing all these fancy adult dentistry full mouth courses. And Brian sees children and teens and a lot of adults in his practice. So he's one of the best people to bring on and to really understand. He's had these devices since year 1. So he understands both in the pediatric dental community and the adult dental community much more than I do, because he sees 10 times more of the adult patients than I do. So if you have questions especially on now the QuickSleeper5, please reach out to any of us. I would say Brian and I use the QuickSleeper the most. Ann is using it some, but she's a certified master on SOAN and SleeperOne. But any of us, please reach out if you have any questions. And there's a whole whole bunch of other people on here, and we've got a lot to cover tonight. But you see Sarah there and Matt, and there's a lot of people that are responsible for teaching, especially the SOAN and SleeperOne. All right, just another quick thing about me. So I started with New Smile, actually introduced to them in residency, and that's the time where they had the metal crowns or the white facing signature crowns. They're still sold. So I've seen New Smile go from it was never a small company, but a smaller company to this unbelievable force in pediatric dentistry, and that more to come that you see on the lower right. Now there are new crowns out, and I swear every other day there's new things coming out. So they really position themselves to be the all-in-one source for pediatric dental education in new devices. They brought these devices into the U.S. With a lot of time and a lot of money and a lot of effort, so I appreciate that. And I use everything on here. I think I used 2 pounds of Biosum yesterday during GA. One of the important things to understand, and I mentioned this at the beginning, is that I personally feel that IO administration of local should be the standard of care. And all of you that use these devices on a daily basis, you already know the direct impact it can have in your practice. I will tell you, I do very little oral intranasal sedation anymore because on 2 and 3-year-olds, they don't feel the injection, right? It's completely changed the way I do so much with restorative care. And really the only way to become an advocate is to learn these devices. Hopefully at some point you'll wind up with 2 or 3 of them and be an advocate. So when you see something online about IO, mention it. People have questions, please get out there in the community and talk about this. This is why I volunteered my time to do this tonight, because I really feel this passionately about these. And, Brian, Ann, all of us, everyone at New Smile feels the same. Although these devices are new, one of the things that I think is important for all of us to realize is, number one, we are late to the party getting these devices in the U.S. Everybody, New Smile and Dental High Tech and Dental High Tech America understand how difficult it was to get these into the U.S. and the unbelievable amount of work it was. These devices have been in Europe and many other places. We're on QuickSleeper5 now, and we're on SleeperOne 5, so that means there was 5 editions. So we are late to the party. But the actual idea and the concept of intraosseous anesthesia came from the 1900s, right? Dr. Nogi talked about that all you have to do is get through the bone, and then if you inject into that mesh of cancellous tissue, into that medullary space, anesthesia is immediate and absolute. And I will tell you that is as true then as it is today. The difference is we have electronically mediated devices that greatly improve the safety and the ability for us to give a painless injection. But the idea of truly intraosseous local anesthesia, it's not new. Even before these devices, we had the X-tip. We had other devices that you would manually drill through the bone. The key here really to safety and for the painless aspect of these devices is the electronic anesthesia, and we're going to talk about that tonight, okay? So a lot of things have changed in our offices. Now we have digital x-ray and we're scanning and we're printing, and there's been this huge, even in the 23 years that I've been in practice, change. And if we look at local anesthesia, nothing's really changed, right? But now that we have these 3 devices to deliver a completely new way of having our patients be numb and have it painless, I will tell you without fail that out of any 3 of these devices, 9.8 out of 10 times, my patients do not feel anything besides maybe a little bit of pressure. Okay. I follow all the rules. I'm careful with angulations. Some of you may be on the webinar tonight because you're telling us, wow, it hurts every time my patient receives an IO injection. There's a reason for that, I promise you. Or it's not effective, or I just gave up on it. Hopefully there's not too many of you that feel that way, but I will tell you that it is always having something to do with your technique. And there's a huge army of us now that use these devices solely on a daily basis and can tell you that I don't need studies now after 2 years. I know that they work. I know you can give an injection almost painlessly or completely painlessly, and they are effective. I don't find there's a reason to use a manual syringe at all in my practice whatsoever anymore. Okay. One concept that I think it's important to understand is I want local anesthesia delivery in my office to be like a light switch. I want it on and off. What I care about is taking care of the restorative dentistry or the extractions, or, if you're a GP, implants or osseous surgery or soft tissue surgery. I just need to make sure that it works. I don't want to worry about having to wait. I don't worry about things hurting. I don't want to upset my patient. So I like this concept of a light switch, right? So when I go into my bedroom at night, I don't have to fumble around where the light switch is. I know where it is every single time, right? And I know if I click that light switch, it goes on and off 100% of the time. I don't have to figure out an angulation. I don't have to figure out, how to get to it. It's just on, off, right? I don't want lag time. I don't want my light in the bedroom now to work for the down the hall, right? To turn the hall line on and off. I just need it to work and I need to go to sleep. And that's how I need local anesthesia to be for all of you. I want it to be painless. I want it to be instantaneous or almost instantaneous. And I don't want you to have to think about it. Now, if you're new to these devices, I was the same way 2 years ago. I had all the instruction manual out and the videos, and I was going into, so focused on doing everything right. And now I just don't even think about it. And I can successfully give an intraosseous injection pretty much to any patient at any time, and I just don't have to think about it anymore. And that's what we want for all of you to get to, and you will be if you dedicated to it. So, why do these provide a benefit to our patients, right? Why does it make sense to even spend any money on these things? I hear from docs that say, well, I'm pretty good at giving a shot. I hate that word. I'm pretty good at giving a shot, and why do I need one of these things? Well, I already alluded to it. I will tell you that I can truly, and if any of you want to come visit my office, I'm happy to, or any of the people that you saw earlier tonight, is that my patients almost 100% of the time don't even feel the initial stage 1 of giving soft tissue anesthesia. You have to be careful with the angulations and your patient positioning and all of those things. But if you do those things, you really can give a pain-free injection. All right. And if there was any doubt on if these work, there's a great study. I know some of you are in academics. So if you want to take a scan here, and this is, a reputable journal, right? This is our International Journal of Pediatric Dentistry. And so their study was 79 patients, 6 to 12 years of age. They gave a block, or they gave an infiltration, or they gave an injection with the SleeperOne. And basically what they came up with, the findings of the study, is that children in the SleeperOne group reported significantly lower pain scores during needle insertion, anesthetic delivery, and treatment. Post-op discomfort decreased significantly, especially at the injection site. So that's a big deal, right? And people ask for studies, and I think this is an important one. So thank you for this. And this was Anne's slide. I love that. Thank you, Anne, for that. All right. Another huge reason why to go to local anesthesia delivered intraosseously via an electronic device, say that 3 times fast, is I have not had a patient have a numb lip or tongue in my practice since I started under 14 years of age. And then recently, I'm not giving blocks anymore. I can't even fathom picking up a syringe and giving a block to a patient anymore. There's no reason to do it. And all of us that have been in practice for more than probably 3 weeks have had this situation where parent calls you and they think their child's having an allergic reaction, or you're getting a call from the ED saying, you gave the child some medication and did you really check they were allergic? And then you get attorneys on the phone, right? We just don't have this anymore. The only time I will advise my patients to not eat or drink after an operative restorative appointment is if I'm worried about, waiting for cement to dry or something else. But, or, for extractions, we're giving instructions about, of course, soft foods and no straws. But everything else, go for it. You have you finish your op at 12 o'clock and you just did a whole quadrant of composites. Your patient can go have lunch right away. It's actually a big deal. It's actually a very big deal. And we do not have collateral numbness. If you are having any, because this is an advanced webinar, if you are having any collateral numbness with your patients, you need to let us know and we'll talk you through it. It's probably because you're giving too much at stage 1. All right. So most of you are not new. So here's all the things, right? We only have to give 1 injection. I just recently had a quick sleeper injection for the first time. Well, I'll save that story in a minute. So no collateral numbness. You can work on both sides. Do not worry about midline anymore. I had a patient last week. We did S&T. I wasn't sure how it was going to go, so we scheduled a little bit longer appointment. Normally, I would have had to come back 2 years ago. I would have said, okay, come back for another visit. Nope, we got K&L done. Don't have to worry about midline anymore. You're only numbing the teeth in that quadrant. You can hop over. Just forget about midlines. It doesn't exist anymore. And that's how these devices truly, one of the ways they pay for themselves, besides internal marketing and a bunch of other things, is that you can add treatment very easily right away. I just talked to a GP friend of mine, one of my close friends, Dan Hendrickson, who's in Washington, and he actually had a teen that he saw, and he did 19, and he normally would have had them come a different visit, but patient did great, and he went and did the other side, had a couple got 2 quadrants done. Normally that would have been a single visit and then bringing the patient back. You can, when we say no delay between anesthetic delivery and active treatment, that is true, but there's some caveats, and I have, after I've taught this for a while, there's a few things I'm teaching slightly differently. I'll just explain it right now. When we say immediate treatment and the immediate working time, that is for teeth. That is for pulpal anesthesia. And the reason why I say that is because when you administer an IO injection, we have to remember that you're going straight into that medullary space. So in order to, let's say on the lingual side, if you've given on the buccal, in order for that local anesthetic to travel through the cortical plate to the soft tissue, it takes a little bit of time. Okay, not much. It's also dose dependent. So again, it's intermediate for most patients most of the time. But if you are experiencing, you know what, I'm feeling on the lingual side, I went and anesthetized the buccal of S&T, and I go to put a rubber dam on immediately and they feel a little bit of the clamp, you may need to wait just a little bit, but also that's dose dependent. Also, now with a quick sleeper, when I just had my first injection, and it was between 2 and 3, and they went ahead and delivered that intraosseous injection between those 2 teeth, I was immediately numb, 2 and 3, my entire soft palate. It took a few seconds, and they were kind of tracking along. Took a few seconds for that local anesthetic to travel towards the midline, because remember, need to wait for a little bit of blood flow there. So I would say, again, it is immediate for teeth. Soft tissue, you may need to give it a couple seconds or a little bit and just double check the opposite side for you're giving the injection. 100% better behavior management. As I mentioned, I used to do a fair amount of oral sedation, and I have a parenteral permit and intranasal and submucosal, and the amount of sedation that I do now is almost zero. I may actually unfortunately have to give up my sedation license because we do a lot of GA, but I just find even little ones, 2-year-old, I can give a painless injection. I can take out D, F, and G without them feeling it. And the anesthesia that I find now for patients, much more profound. Less stress for parent, less stress for me, less stress for my staff, and less post-op problems. Okay. So, as for blocks, since we're going to talk about Quick Sleeper tonight, I love this drawing because this diagram, right? It's a drawing, because what we realize is when you're trying to give a block on the lower, it is not just the IA, right? I had a previous employee that needed some dentistry done. She said, I'm really hard to get numb, gave her a block, and this was 3 years ago, could not get her numb. Could not, block. I did a mental well. We sent her to the oral surgeon. She had a CBCT. Well, she had a few areas of accessory nerve canals on the lingual side of her mandible that I never would have known about, right? I wish I would have had IO at the time, but there's all these other nerves that feed, especially into the mandible, and we just don't have to worry about this anymore, right? A block, we have to worry about it. Don't need to worry about this anymore. And there's all these accessory canals. And this used to be, a pain, right? You go ahead and give a patient a block, and it's happened to me, a lot more than once. And I give a block, and I go to get started, and they're still feeling it, right? And then you've got to maybe go do some recall checks, and then come back and then give more local. And by the time you're done trying to get this patient numb, you either have to stop because you've administered too much local anesthetic depending on the weight, or you just can't get them numb. And I don't worry about that anymore. I don't care what age of the patient. Now that I have 3 devices, 16-year-old, 17-year-old, 25-year-old, as I've gotten older, my patients have gotten older, and I do treat, a fair amount of older teens and young adults and, some adults. And yep, I'm actually, next week, I'm treating a fellow GP, and I'm not going to worry about his local, I'm just going to give an IO with QuickSleeper, and that's it. So what do they look like? This used to have 2 pictures. Now it's got 3. So we have SleeperOne and SOAN, and then now the QuickSleeper. So all of these you can get from New Smile. They distribute these for us and give all the education and everything, support everything through them. And now you have the option of using a device for little ones and maybe young adults, where my cutoff is now is if they're 13 and above, I don't even think about it. I just go straight to my QuickSleeper. Okay. So here's some differences. All right. Between the SleeperOne and the SOAN, the business end, that needle is exactly the same. They're both designed for primary dentition and mixed dentition. Again, my number is 13 to 14 years of age. Anybody older than that, you can absolutely use SOAN and SleeperOne, but you're then, again, manual bone penetration, you are having to push through the bone. If I have to think twice, I'm grabbing my QuickSleeper because, and we'll see tonight, that is a Swiss Army knife of local anesthesia. I never have to worry anymore, even if I have that 14-year-old who's, could be a linebacker for the NFL. And I was a little worried about trying to get, SOAN or SleeperOne with the manual bone penetration with the 9mm. I don't worry about that anymore because I step once on the pedal and I maybe give it one or two rotations and pop, I'm straight through. So again, SleeperOne, SOAN for primary dentition, mixed dentition, and then any age is QuickSleeper. Really, the 2 main differences between SOAN and SleeperOne are cordless or corded. Personally, I love the SleeperOne. I like the feel of it. I'll show you a picture of it in my office. If you were only going to buy one device, what would you do? If you are willing to spend a little bit more money and you want the jack of all trades and not have to worry about anything again as far as age-wise, I'd buy a QuickSleeper. If you're going to move it from operatory to operatory, you have a younger practice, you're going to buy a SOAN. If you're going to keep it in one operatory and you're pediatric or a primary mixed dentition, then SleeperOne. Okay. And so what do they cost? There is a cost difference between all 3 of them. I'll say it out and everybody may gasp a little bit. Oh, yeah, it's more expensive. Here's the thing you guys need to remember, because I kicked a little bit when I saw that amount. These are drug delivery devices for patients. So there is a lot of time and money that goes into these devices. I can tell you that the rate of return on these are not as high as you think they are, because it costs so much to get them through FDA and get them in your hands and offer training and all of these things. Okay. What also didn't help is tariffs, because these are coming from France and the cost has increased on these because of the tariffs. They are not made in the United States. What pricing is not on here is combinations. And again, I'm not a salesperson. I don't sell you anything. They will make these. If you contact New Smile, they're just putting pricing together now. So if you say, hey, I'd like a QuickSleeper and, SleeperOne, what can you do for me? I don't know what those pricing programs are, but they will have them at some point.
But I'm coming, Josh.
Yeah, go.
The SOAN price actually $31.95, but we're offering a $500 discount through the end of the month. I'm not sure this pricing looked like introductory pricing from years ago, but I'm sorry that they sent you that slide. But
okay, so what is the correct pricing again? Tell me.
$31.95, but they're New Smile's doing $500 off through the end of March.
Okay. All right. So that's all the sales stuff. Again, I'm a clinician. I don't get anything from you guys buying these, except it just makes me happy. But if you're going to buy only one, I say buy once, cry once. I would buy a QuickSleeper, and there'll be lots of training. And between all of us that are experts, I can say I'm an expert in this because I'm using it for a while. We will get you trained, and we will make sure that you learn how to use these devices. I did a training in the hotel this weekend for a dentist, 101 for QuickSleeper5 at the CSPD. So there you go. All right, SleeperOne. So it is cordless. Let's talk a little bit about the pedals. Here's one thing I want you to know. Between the SleeperOne and the SOAN, the order of the pedals is opposite. So a good way to think about it for the SleeperOne or the SOAN is the green pedal there is the drop by drop. So you're going to give that for your stage 1. Then to go ahead and deliver the bolus of local anesthetic, you're going to use the larger pedal. Remember B for bone. Okay, so for the SleeperOne, there's 3 colors. If you look on the upper right there, blue, pink, and orange. B for bone. B is for intraosseous. I'm going to drop the mic. I got so excited. If you're going to give intraligamentary or a PDL, you're going to go to pink. And if you feel like you want to give a block, which I don't know why, then you can use orange, or for an infiltration. You can give blocks with these. It will aspirate. I've never done that. You might as well use a regular syringe, I guess, but that's it for SleeperOne. This is one of my operatories, and one thing it's very clean. We had the SleeperOne just wired in through the arm there, so it's super clean. You can see the device. You see how it is upright right now. Don't do that if it has a cartridge in it. So if it has a local anesthetic in it, you want to keep it the opposite way, so the needle facing down. God forbid that you've got a crack in, you got a bad cartridge of local anesthetic and it drips. You don't want to drip into the unit. So that's one of your key tips tonight. Flip it over. Okay. Comes with a holder, and you can use that to mount it. And this is how I have it in my office. And then the SOAN. Most of you that are going to buy the device only for young ones, you're going to go with the SOAN because it is portable, and it has. We won't go into this in detail, but it comes with instructions. There's a lot more options in the SOAN. Now, the only thing, and I love Ann talks about this, is the fact that if you have a lot of associates in your office, it's easier to hit buttons on these things and change something. Tell everybody, don't touch a lot of buttons. You can move it from operatory to operatory. I find most people wind up with more than one of these devices. Okay, so I talked to a doctor last night, happens to be on, and I said, if you're going to buy 2, I would buy a QuickSleeper and a SOAN. Okay. But that's going to be up to you. You can change the sound. You can change if it's cruise or drive. What's the difference there? Drive is you step on the pedal and it'll just keep on going till you let go. Cruise is like cruise control. So you click it once, it'll give a predetermined amount of local anesthetic and it'll stop. I have mine set at, I like drive, but I haven't set it at half a carpule. So mine will stop at a half. Totally up to you. You can set those settings yourself. Now, SOAN on the pedal, a little different. It's just B for bone or pink for infiltration. So if you're going to give infiltration around like an exfoliating primary tooth, then you may want to click that to pink, but most of the time you're going to be in blue. As far as the canisters, once these start cracking, please make sure they're not uber expensive, at least 50 sterilizations. But once these start cracking, please let your teams know. Toss it and grab a new one. We just have packs of them ready to go. One thing to point out for QuickSleeper5, it uses the same canister as the SOAN, so you don't have to worry about having 3 different canister types in your office. What we do, because we have all 3 devices, we just use sterilization tape that has different colors, and we label them so we know what's what. All right. So this is the QuickSleeper5, and Brian, who's here on tonight, that's his picture, and we're going to be like your go-to people for these devices. I said Ann Bynum uses this as well, but we are going to be training, I think, the most out of all these on the QuickSleeper itself. And again, the advantage of this device, it is corded, but the difference is you see the metal container in there in the end, that spins. So this device will rotate and deliver local anesthetic all together. And it comes with instructions like this. We will help you through all this. It will come with onboarding. One thing to point out, the buttons are different. They are opposite. So ask me how I know. I learned that once. I won't do it again. The small button is to rotate. The big button is to administer. I won't go into super detail about that tonight, but these are wireless foot pedals. One thing to note for any of your devices, if you find you're stepping on it and it's a no-go, you can't deliver, it's because it's likely underneath your chair that's made of wood and plaster and foam and everything else. Move it to the side a little bit, okay? But these come with instructions. I don't want to go into detail on those tonight, but I do want to start getting in the meat and potatoes of some advanced concepts. We are delivering right towards the apex, right? Now with QuickSleeper, we're rotating the needle so you don't have to worry about manual bone penetration, and we're giving as close to the apex as possible. I like the idea of an orange, right? So the orange is your cortical plate, and the fruit of that orange, the inside, is your medullary space. It doesn't matter here in your cortical plate where you pop through into that medullary space. You just have to get into the fruit. Same thing like an orange. So now that we have the QuickSleeper5, we have the ability of any age, doesn't matter how thick the plate is, doesn't matter where you want to enter the bone, it will rotate for you 12,000 times a minute, and you're using most of the time a 16 millimeter needle, and you can pop straight through into that medullary space and deliver, okay? I'm going to speed up here just a little bit because I want to cover as many things as we can tonight. You guys know dental anatomy. The angulation of these devices are important, and I will show you holding the devices tonight. But a little bit more of a basic concept. Remember when we gave an infiltration, we were giving a bolus of local anesthetic facial to the periosteum, right? So you had to give a larger bolus that had to perfuse through the Volkmann's canals and virgin systems to get into that medullary space. The difference now with intraosseous anesthesia, we are delivering opposite. We're going straight through into that medullary space as close as the apex as possible, and it's working backwards to the soft tissue. That point is important for the fact that when we talk about instantaneous local anesthetic delivery, it is instantaneous for the tooth. Sometimes you need to wait a little bit to allow that bolus of local anesthetic, remember, to flow backwards now, the opposite direction to get to the soft tissue. That's an important concept. If you're using a 9 millimeter needle, people ask about the erupting tooth bud or developing tooth bud. If you're using a 9 millimeter needle and you're getting down to developing tooth bud, we got to talk. You are nowhere even close to that. So I do not worry about that whatsoever. So how does this device work? I want to show you actually. I want to show you the real deal here. So this is a video Paul Bond. So this is stage one. Stage one doesn't matter if we're giving this with either all three of the devices. First step is we've got to numb the soft tissue, that papillary triangle, and then the periosteum. This takes 7 to 10 seconds. The time is as important as blanching. You want to see blanching just in that papillary triangle region. And then once that papilla is numb and we know the periosteum is numb, we don't want to rush the step. I want you to have perfused local anesthetic delivery there. So it's got to be blanched. Then we're going to switch positions. Now, again, this is for manual bone penetration. So this is for any of the devices using a 9 millimeter needle. We're going to push, 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 pop. You see that pop through? Then we're going to deliver our local anesthetic. Now, I'll show you the new thing. Now with the QuickSleeper, it's a little different. We're going to give that stage one. I don't know. Can you hear the sound of the music there? I'll talk over it. But we're going to be giving stage one. We give this maybe a little bit lower in that in the triangle, more at the base of the triangle, because I'm not as worried about thickness of the cortical plate. I would tend to choke up a little bit higher on the plate so it's thinner. I don't worry about that anymore. So we're going to deliver our first stage. And we really want to make sure, especially for a rotating needle, that you've got diffuse blanching just in that base of the papillary triangle. And once that area is numb, now we're going to switch positions. We're at about a 45-degree angle. We can go in the same hole if needed. We're going to just lightly contact bone. We're going to step on the pedal, and now you're going to see that rotation. And this is the magic. Spin. You see it rotate? There's one pulse. There's two pulses. See, we're coming in and out a little bit. And 3, 4, now we're in. Okay? Now we've gone through that cortical plate and thicker bone, and everything runs beautifully. This actually delivers very quickly because when you're deeper into that medullary space, there's not as much back pressure, and I find it does deliver faster. I want to show a video here of Brian Richards delivering. So this is a teen patient.
No, I need to see the yeah.
This may be weird for Brian being in Costa Rica and seeing his face at the same time. So here we go with stage one. You see we're a little bit deeper in that papillary triangle, right? Because we want to get really into that medullary space. 7 to 10 seconds or so, patient did not even react. If you notice, there's that metal gate and the D is facing out. Doesn't matter which needle you're using, which device, that D is always facing towards, away from the gingiva. And Jamie, to answer your question, we are not using topical. I do not use topical in my practice whatsoever. So there's our stage one. We're going to give diffuse blanching. So this takes, maybe 10 seconds or so. Needle comes out. He's being super careful so we don't have ucky taste. Now we're going to switch to the next position. So we're at about 45 degrees, light bone. We're lightly contacting bone. Here comes our rotations. There's one. There's two, and he's through. And I think he's, yep. And now we're all the way in the medullary space. So now that's a 16 millimeter needle. We don't have to worry about, with a teen and a 9 millimeter needle only being able to numb 2 teeth there, because that's often what we got. Now you've got that full quadrant. Okay. So the concept of electronic delivery is important, because if you try to do this by hand, I promise you, you can't deliver slow enough to be effective. So we've got to use electronic device. All the rules for all 3 devices remain the same. It's dose dependent as far as how many teeth we want numb in that quadrant. So if I'm only numbing, 2 primary teeth, I maybe give on back-to-back composites. I may give a quarter. If I want to do pulps and crowns in that quadrant, I may give a half cart for the patient. But it's dependent again on what anesthetic we're using. We'll talk about that tonight. Let's talk a little bit about diffusion. Now, if you have if your needle is sitting into that medullary space, now with a teen or an adult, you're going to need a 16 millimeter to do this. For a child, easily a 9. We talk about that the upper arch, you have omnidirectional flow. So I will guarantee you'll get 2 teeth distal, 2 teeth mesial, and you'll get all the palatal tissue. When that was done on me, I was numb instantaneously on my soft palate, all the way to the midline. And then on the lower arch, you're going to get 1, and this is at minimum, you're going to get 1 tooth distal and then a number of teeth mesial. In my from so far what I've seen with primary teeth, let's say you're going to numb between 30 and T, you're going to get 30 numb, and then usually up to the canine, depending on if you give about a half a carp. If you're only giving quarter carp, you're not going to get that far. All right. So again, max 2 forward, 2 back, and the mandible 1 back and 2 forward. That's pretty much guaranteed. We don't have to worry about midlines anymore. Most of you know about the needles, and I won't go into detail there, but I will tell you now, there's really 3 needles that we use. And in my world, I know that 16 millimeter 27 exists. It's a larger bore needle. I haven't found that I need it. When I asked Dr. Prin, he's rarely used it, and the entire time he's used these devices. But in my world, for children, or for primary or mixed dentition, I'm using the 9, which is green. And if it's a teen or an adult, I'm using 16. Make it really easy. Use those 2. Now, with QuickSleeper, you can put a plastic cartridge container on and a 9 millimeter needle, and you don't need to rotate. So you still can use the 9 for either one of the devices. If it's SOAN or SleeperOne, technically you could put a 16 millimeter on there, but you're going to probably wind up bending the needle, because it's really meant to rotate just because of the length. And I will tell you, if you keep your angulation at 15 degrees, you keep the D facing out, you should be able to give a painless first step here, okay? But you've got to remember that D's got to be facing out, and you've got to be at about 15 degrees. If you change your angulation, what happens is you're poking and not really slightly lancing the tissue. The number one reason why doctors complain of their patients, I should say, complain of pain, is they didn't start at the middle of that papillary triangle. They went too far distal, let's say in this orientation, and they started delivering to the PDL, or they actually punctured the PDL. I'll show you in a slide in a minute, but I bisect that papillary triangle and I go slightly mesial or slightly distal too, okay? 15 degrees is key. The needle is designed so you're just slightly at a pitch away from the tissue. I want you to think about just bending the needle on the tissue. Just bend. Dr. Prin taught me that early on, and that's what I think about every single time. If you poke, you may push too far in. Just lay it on the tissue and slightly press. If your angulation is correct, your patient should not feel that injection. And Dr. Laree talks about the circle of safety. We don't stay this far away from our patients, especially now with QuickSleeper. I pull them in a little bit closer to me, okay? Really quickly about local anesthetics. Topical, someone asked, I don't use it anymore. I got sick of using compounded topical and having tissue burns. You will find, you may use, because you're worried topical at the very beginning, I don't use topical for anything anymore. The 2 local anesthetics that we use the most are both Septicane, one at 100,000. That's what many of you, if you started with Septo, you're used to using, or 200,000. The 1 to 200,000, these are just the epinephrine concentrations, but we're using 4% every time. The difference really becomes, people always ask, which one should I use? Make your life easy. If you only want to pick one, buy 1 to 200,000. Okay. The only time I use 1 to 100,000, if it's a longer procedure and I want to lengthen the treatment, the effective time, I will go to 100 to 100,000. Or if it's a really infected tooth and I'm trying to keep as much local anesthetic in one place possible, I'm going to use the 1 to 100,000. But vast majority of the time, the 1 to 2. Why do we like Septicane? The fact that it starts to break down in the bloodstream versus the liver. And we know that perfusion is faster just because of those theophylline rings, and the perfusion through soft tissue is faster. We don't need to give as much local as we did before. I know we're going fast, you guys, but we got a lot to cover. You don't have to give as much local anesthetic as you did previously because of the fact you're giving it right at the source, right at the apex. So what are our injection sites for primary mixed dentition? There's really 4 that I use the most. It's going to be either between S&T or the maxillary incisors or mandibular incisors. I do follow this rule in primary dentition or in mixed dentition is 1 distal and 2 mesial for the amount of teeth that you can numb. Okay. If these devices only worked for the max or mandibular anterior, it would be amazing. I take out teeth all the time. Just did it the other day. We took out 4 primary incisors. I gave 1 IO injection between 8 and 9, gave a half a carp. Patient was profoundly numb, took all 4 teeth. They didn't even flinch. Okay. You can numb and you can get to cuspid to cuspid. I would check tissue on the cuspid to make sure you have profound perfusion there, profound local anesthetic. But when it comes to DFG, no problem. All right, let's talk quickly about the 3 steps. Here's the first piece of advice. Don't start to inject right the middle of that triangle. Go a little bit mesial or a little bit distal, and that way your local anesthetic will advance without getting close to the PDL. We know this is a 3-stage injection. So number 1 is our soft tissue and periosteum. Number 2 is in our positioning, our bone penetration, either manual or rotation, and then 3 itself is the delivery of the local anesthetic. Okay, I'm not going to go through these 3 steps because, again, that is part of the basic course that we teach. But number 1, you've got to make sure your papilla is numb. If you don't see profuse blanching at that papillary triangle and only that papillary triangle, you need to make sure that you deliver more anesthetic. You don't want your patients, you don't want to get anywhere close to your periosteum. That's when things won't feel so nice. So we talked about manual bone penetration. Now with QuickSleeper5, we're either manual bone penetration if you're using a 9 and a clear container, or with a metal and a 16. Okay. For those of you worried about for manual bone penetration, why don't I feel a pop? Younger patients, you're not always going to feel a pop, okay? Older patients, you will with manual bone penetration. Now with QuickSleeper, you're going to feel a slight rotation or like slight vibration. That's what I tell my patients, especially teens. I tell them it's going to vibrate just like you would with a cell phone, but after that, all they feel is vibration, and that is all, okay? If you do want to practice, I think even with an egg or a Capri Sun, I like a cardboard box. And I find if you just use that 9mm and just push a little bit in cardboard, that's really what that feels like. And again, SOAN and SleeperOne, you're going to use the big pedal for your main delivery, small pedal for that stage 1. With the QuickSleeper5, that small pedal is for rotation, big pedal is for everything, even stage 1 or delivery. Okay. Important slide, at least important to me. These are the mantras that I say every single time before I give an injection, still 2 years later. So I call it the 4 Ps. People have heard this before and probably sick of me saying it, but it's what I do in my head. Number 1 is power. The last thing I want to do is go ahead and give my stage 1 and try to numb the soft tissue and the unit's not on. Your SOAN will shut off at a certain amount of time. Your QuickSleeper or your SleeperOne will not shut off. You can change the time on it. I would just leave it as is, but please make sure it's on, number 1. So that's your first P. Number 2 is your plan. Check your radiograph. Figure out what local anesthetic you're going to use. Did I mention look at your radiograph? And did I mention look at your radiograph? We're never going to take out a tooth or treat a tooth without a radiograph. We want to make sure that there's good bone, healthy bone in the area. There's dense bone. If you see there's a big lucency, there's not a lot of bone, you're going to need to go to a different site. And then pedal. I will make sure that pedal, I will test it every single time. The reason being, especially for the SOAN, because it's got to deliver from that pedal to the SOAN itself, is the fact that I want to make sure it's talking. If it's way under your chair, it may not talk. So I will test it once. So is my pedal in the right position? And then I'm going to make sure that my patient, my doctor's my foot position is all correct, and then I deliver. So power, plan, pedal, and then my positioning. People, we have had a lot of questions about lights. Let's go over that again quickly. So your SleeperOne should be in blue. You see the blue light there, circumferential around the unit. That is going to be blue for bone. Pink is for your PDL for your SleeperOne, and then orange if you're going to use it for an infiltration. SOAN itself, same thing. B for blue, B for bone. It's going to be for your intraosseous injection. If you're going to, I do sometimes switch it for if I'm going to give an infiltration, I would put it on pink or purple. Here's one thing I want everyone to remember. If you have over-retained teeth and it's just soft tissue, it's just gum tissue holding that tooth in, personally, I don't give an IO injection because there's no reason why to go all the way in the bone to try to get to that soft tissue. And if that soft tissue is not attached and it's slightly off the bone, you may not get good perfusion there. So for those of you that said, well, for over-retained teeth, I'm having a problem, put it in pink and just go ahead and give an infiltration around those teeth. I don't think you need to worry about giving an IO. Beeping for your SOAN specifically. Most of you have SOANs that are on tonight. One dot blinking is okay. 2, you're still good. You start seeing 3, start looking for pressure. And if you start to see 4, it means that there's too much pressure in the system. Most of the time, that's because you may have had a bony spicule or soft tissue blocking your needle. So what do? And again, these are all the things that could happen if you do have too high of a pressure, the needle's bent, or I think most of the time you've got something in the cannula. Give it a little time. Don't start doing anything right away. Give it a few seconds to see if it autocorrects. Then back off the needle a little bit. Try to continue to inject. Remember that any of these devices will keep you safe. It will not allow you to give at too high of a pressure. All 3 of them will shut off on you, will not let you do it. If that needle is blocked and it continues to see that there's a pressure issue and it can't deliver, it will automatically reverse and it will pull that plunger back out and won't let you deliver. And if you need to, you may need to change position or put a new needle on. If I had to think twice, I'm putting a new needle on every single time. But if you just remember, if you come off the pedal, your pressure curve is going to change. Remember, when you step on the pedal, it's going to go from slow delivery until it delivers for a little bit and then speed up. If you come off, you're going to have to start that cycle again and it will take you longer. Really quickly about angulations, thank you so much to my dear friend and amazing educator, Paul Bond. These are for the upper right quadrant. People asked for this slide specifically, so you may want to take a screen print, or if you need these, we can get them to you. So stage 1, if you are on the right-hand side for the upper right, you can, now he's delivering vertically here for stage 1. That's an option. I'm a bigger fan of going horizontal. You got to be careful if you're going to give vertical stage 1 here, because you can touch the bone a little bit easier. My preference is horizontally. Okay. Remember, if you need to, you can give this injection on the palate. I do it all the time. There's no more sensation than doing it on the buccal. But that's your upper right. Upper anterior, you're going to be straight on with that patient. You can give it to an ENF or 8 or 9. If you need to go 1 tooth over, you can do that. Upper left, depending on if you're right-handed, you're either going to give in that position either horizontal or vertical. Again, horizontal I think is safer, but there are many times that I will give palatally here because I'm right-handed in the upper left quad. And then lower left, you're going to rotate your patient towards you. That's what I do most of the time. Again, you can give on the lingual if need be. The lower right is usually where most people start if you're right-handed, to start getting used to delivering with these devices. The angulations are a little bit different. I think a little bit more important for the quick sleeper. I'm not going to go through those tonight, but I do want to show you for the lower left, if any of you do wind up purchasing one. If you see Dr. Prin there is actually, he's switched sides to the patient's left. It is easiest to rotate. When you have a rotating needle on these devices, it's far more important to make sure that your long axis and your vision is directly on. And if you choose to join us and purchase a quick sleeper, which I hope you do, we will train you on how to use the devices in patient angulation. You'll have more training than you need, I promise. Okay. And again, palatal access, you can give it. So just a couple things as far as reminders. You've got to look at your radiographs. I know it sounds silly, but I've had people send me radiographs and said, I had these abscess teeth. I couldn't get the patient numb. Well, that area had a giant periapical radiolucency in it, or the tissue's marsupialized, and you don't have good bone. If you are going to deliver in, let's say, that lower left, and you try to give between the primary first and second molar, you're going to have an issue with profound local anesthetic because you don't have good bone. Remember, you need to give in an area where you've got solid bone. So in this case, you may want to think about giving on the lingual side, and that's what I would do in most cases. For the anterior for primary teeth, there was a question someone sent to us they want to answer tonight. How much do you give? I typically about a half. Most patients for primary mixed dentition, if I'm giving any of the 4 posterior quadrants or upper or lower anterior quadrants, I'm giving about a half. All right. Now for quick sleeper, for teens or adults, most of the time we're giving about a carp. Okay. I will tell you that seeing vasoconstriction, it's not always 100%, but I do want to see it. If I know I've got vasoconstriction after I've delivered that bolus of local anesthetic, there's a pretty good chance I've got profound facial, lingual, palatal local anesthetic. Okay. My favorite situation that I had initially with this device, I had a patient who was very anxious. Mom was anxious. The orthodontist asked for NOPQ to be removed. In my hands, this would have been, several injections. And this kiddo got 1 intraosseous injection between O and P. I gave a half a carp, 1 to 200. I took out 4 of those teeth immediately. She did not feel a thing. Again, please remember, primary teeth, if they're over-retained, it is a waste, in my opinion, to give IO here. Put your unit into like pink, let's say, or into whichever device that you have. It's basically outside of blue. And I would give just soft tissue here. There's no need to give IO. You can give IO if you want. However, please remember, you may need to give a little bit of time for that perfusion to go backwards to how you normally work. For a quadrant in the lower left or lower right, let's say we want the 6 and all 3 of those teeth to be numb, I will typically get the first molar and the permanent first molar, the primary first molar, and the primary second molar completely profound. I will double check if I'm doing a pulp on the canine. If I give maybe 3/4, usually I'll have a completely profound local anesthetic there. But this is dose dependent. If I'm only doing a few composites on a few teeth, sometimes I may only give a half a quarter carp, and I will, that's enough. Okay. Angulation is important here for both your first stage and your second stage. All right. And there are lots of videos that we have. Again, tonight we're kind of going through all 3 devices, so we're not hitting too many cases, but please make sure, and this is key point, I can't tell you how many times all of us have had calls and emails about my patient having pain. And I usually find it's right-handed doctors on the lower left quadrant, and they injected too close to that 6 or too close to the E. So your initial delivery there for stage 1, remember D facing out, that's perfect. Split that papillary triangle in half, give it a little bit more mesial, let that fluid drift slightly distal. Don't get too close to your molar, okay? If you see that you've got a radiolucency, remember you're gonna go 1 tooth maybe distal, 1 tooth mesial, or take a step out if you haven't done it before and give it on the palate or give it on the lingual. I promise you it works as well. We do want to look at radiographs, right? Giving especially if you're using the quick sleeper, trying to get local getting a rotating needle between those two molars is tough. What would I do here? I would just give it distal to the second molar. With a SleeperOne, or excuse me, with QuickSleeper5, all your options are open. You can give them the trigonum area. I didn't even know what that word meant until I started training that behind them. You can give it distal there. You can get through thick bone with rotations of that needle. I find in our patient population, I need 1 to 3 rotations, and I am through. Okay. If you you do want to look for ectopic teeth. If you had a developing permanent tooth and it was very close to the surface, you wouldn't, and for some reason, it's sitting between those two teeth, you may want to give in a different position. Sometimes if you have a tight area between that canines, you just have to look at your x-ray. You need to get in when you get in. And prime case here, right, may not be the best place to give your intraosseous delivery. All right, I want to fast forward a couple slides here. I do want to talk about hypoplastic teeth. I treat a lot of hypoplastic teeth in my center and in my practice, and this was very difficult for me for a lot of years because of the fact that these teeth are hard to get numb. I learned early on from Patrick Ruck as far as all the studies behind why these teeth are more difficult. They're actually primed on a cellular level to be more reactive. They're kind of always in this state of inflammation. In my hands, I'm almost 100% success rate giving an intraosseous injection here versus trying to give a block on many of these teeth. Sometimes good luck, yeah. This study, 25%. All right. We just powered through good. We got through our hour. Let's open up to questions because we're going to have a fair amount of those tonight before we wrap up. Actually, you know what? Let me just get through a couple things first, and then we'll get to questions. So if any of you need help, what I beg all of you to do is don't send us a 4-page paragraph and expect us to read through all that and figure out what you're talking about. Doesn't do any good. Send videos. If any of you tonight are struggling and you're having a problem with any of your devices, you're not quite sure what to do, start keeping a cell phone in your operatory, have your patients sign off, have your staff start videotaping your next 10 injections. We're happy to look through those, but if you send us a whole paragraph about, well, the moon was out and I was on my right side and I couldn't, it's not going to do us any good. But typically within the first 30 seconds of the videos we can see. We want to know what local anesthetic you gave, what was your volume, positioning, basically all the details, but a video is going to be the most helpful, all right? There is lots of online support. If you buy one of these devices, it comes with onboarding. If you buy a Quick Sleeper, they will tell you all the information about how training is going to happen, who's going to do your training, but New Smile Tech and New Smile and Dental High Tech and Dental High Tech Americas will not let you buy a device without you knowing 100%. And if need be, if you don't get all the answers, I will get on the phone with you for 2 hours if you need it, and I will, or Brian will, and we will help you with these devices. Okay. Here is your staff of 2 of these people are on, but now that Chris is the boss, where he's doing other things except being on these webinars. But if you have questions, you can still reach out to him. But I tell you, Jordan and Isabella are amazingly, they're available actually too much. Sometimes I give them a bad time because they're answering questions at like 9 o'clock at night on Facebook. Please reach out to them. There is more help than any of you would ever need. Please also use our Facebook group, SOAN and SleeperOne Facebook group. We check that a lot. There it is. That's the Facebook group. Okay, some upcoming workshops. For those of you who have not attended Restore, please do. It is unbelievable the amount that you're going to learn in 2 days. All of the crowns and cements and space maintainers, all the things that New Smile does. And then on the tech day, it's scanning in all 3 of these devices. I don't know, is Pearls sold out yet? I don't know. If it's not, if you haven't, sign up immediately because I'm sure it is going to sell out very quickly. Those are all the upcoming dates for the tech workshops. New Smile is great about having these all over. And when we get to the point of, for those of you that are buying Quick Sleeper, there'll be some other options too that are not on here for training. Again, that is all of my contact information. The rule is if you reach out to me and you don't hear from me in a day or 2, you're supposed to ping me again and say, hey, you're being a jerk. please answer my question. I get a lot of questions. It's fine. I love what I do, but sometimes you got to ping me twice. I will get back to you. So again, Joshua at pediatricdds.com or pediatricdds.com is my training site. And I'm going to turn you over to questions. Good. And I said 6:15. We're right on top.
Great job, Josh.
Thank you.
So please put your questions in the Q&A. Again, it's over if you hit more, and then you'll see the Q&A. Put your questions in there. Just to reiterate, I know you already answered this one, but while we have none at the moment, are you still using topical before stage 1? Just to kind of go over that. I know you mentioned that a few times.
You just asked me.
Are you still using topical before stage 1?
No, one of my team members put topical on a patient. I don't even know where she got it, and I had a conniption. No, I don't use topical. If it makes you feel better for your first couple injections, fine. But I find, and most have found, you do not need topical, because I want you to perfect your stage 1. I want you to get your angulations down. I want you to do all the things that we teach you. So I find I do not need topical for anything. Don't use it anymore. One of my favorite party tricks I did at the CSPD last weekend, and if I have enough time, I'll sit there and I'll put 4 or 5 needles. I learned this from Dr. Prin. I'll just keep on putting needles in my hand until somebody notices, and I may have 4 or 5 needles there, and I don't even feel it. Okay, if we use a 16 millimeter on a SOAN, does it mean we can use it for first and second molar? So your problem there, Cynthia, is using a 16 millimeter needle with manual bone penetration, okay? It'll fit on there, but it is having a long needle and trying to get, I've done it before, but it is really, it was on a younger page. I think they were like 12, and I was just kind of practicing. Does it mean we can use it for first? I'm not quite sure what you're asking there, but most people, if they're going to use a 16, it's going to use it for a block. It's really, you're going to have a hard time with using a 16 millimeter needle on the SOAN or SleeperOne. And I also missed the metal versus plastic hub. Yes, there's a big difference. So you would use the metal hub only for the QuickSleeper5, and that is if you were going to rotate the needle. If you're going to use your QuickSleeper5 like you would a SOAN and SleeperOne, which you actually can, and the nice thing is it's got lights in 3 different areas, you would put the clear container on just like you would with the SOAN and your anesthetic, and then a 9 millimeter needle. How much anesthetic? Hypoplastic molars. Good question. About a half a carpule. Yeah, about a half carp. Bicarb, absolutely no reason to use bicarb whatsoever. I used to use quite a bit of bicarb before I was using IO. I would use bicarb on most teeth. I spent a lot of time working with Onset, and I just find there's no need. It's an extra expense, and it's just not needed. I would use an infected tooth. The reason being is you use bicarb to increase the speed and the ability of perfusion through the bone. It wasn't, and in an abscess, you're not going to deliver in an abscess no matter what device you're using or what methodology you're using, but absolutely no need for sodium bicarb because you're giving your local anesthetic like a millimeter or 2 from the actual nerve of the tooth. What is your kid-friendly way to, I like that one. So I call to parents, I call it a digital pump. That's my way of explaining it. I'm careful about, I don't like to say, it's this new thing, right? Because it's not new. It may be new to you. Parents don't necessarily want us guinea pigging on their children. So I tell them it may be new to the practice. But for a child, I tell them that we're going to take the temperature of their tooth or it's a magic wand. But for parents, I like to use the word, it's a digital pump. And if you're careful with it, you don't want them dropping your SOAN, but what I'll do sometimes, I'll kind of hold on to it and show the child. I'll just take the needle off and hand it to them. And if they really want to, I'll let them step on the pedal. Not while it's in their mouth, beforehand.
Great. We'll give this a couple more minutes for any more questions.
We still have some questions. I'll go over some things that tend to get asked a lot. Again, let me go over all 3. So the QuickSleeper5, the one that's out now, will work for any age and any of the 3 needles. Most of the time we're using 1 to 100,000 or 1 to 200,000 septicane, articaine with just epinephrine concentration is different. But with your QuickSleeper5, you can put on a clear container and a 9mm needle, or you would put on the metal if you were going to rotate, and you could use a 9 or a 16. Most of the time, if I'm using a 9, it's going to be with manual bone penetration. So typically it's going to be metal container and a 16mm needle. For QuickSleeper5, if you're in the wrong location, PDL will automatically turn off due to high pressure. No, it's not going to sense, because if you're in the PDL, you're not going to actually get a lot of pressure there because you're not in a confined space. When we talk about PDL, it's really, if you are in the, it's really more for stage 1. So as it rotates, is looking for pressure. And if you're worried about, is it going to drill through a tooth? We did this at one of the hands-on. We took a bunch of extracted teeth and took the 16mm needle and ran it at a full bore. It is not going to penetrate into a tooth. Okay. Again, I love Lorie's saying as well, so what if you poked your patient in the face with a standard needle? Yes, you got to pay attention. You've got to have your positioning correct. You've got to make sure that you have that patient into your into your circle of safety. But if you're doing all the things correctly, you're going to be fine. What is your rationale recommending septo and not lido? Great question. One of the main things is perfusion, and we know that septo is broken down in the bloodstream instead of until PASA gets to the bloodstream, and then there's just not need for. I want to just keep. Yes, you could use Marcan. You could use a lot of local anesthetics. We keep it the same and just similar for everybody. Keep it simple. It's either 1 to 100,000 or 1 to 200,000 septo. But is there a possibility of developing a tooth bud if it goes in the wrong place? Yes, there's also the risk of extracting a primary tooth and grabbing and developing a tooth bud. Yeah, absolutely. But you're going to watch your angulations. And if you're drilling there, you're not dumping all 16mm into the patient's medullary space. The deepest that I'm going is 9mm. And again, the only problem is if you didn't look at an x-ray and you're trying to drill into a very young tooth bud, but you're going to watch that. This is why you have to pay attention. You could drill into the wrong tooth doing operative too, but you're paying attention to what you're doing. So yes, is there, I guess, hypothetically a chance if you buried all 16mm and you're off angle? I guess it's possible, but am I concerned about that? No. For me, if I had one device now in my hands, I'm using the QuickSleeper for everything. But SOAN and SleeperOne are still amazing devices. It just really comes down to what's your use cases for your office.